Thank you for watching this information video about the MEDLEY study, Methods of Early Detection of Lung Cancer in Primary Care. And this information is directed at general practice teams, particularly in areas where the MEDLEY study is ongoing. My name is Stephen Bradley. I'm a GP based in Leeds, and I'm also a senior lecturer at the University of Sheffield. MEDLEY is a feasibility study, and really what we want to try to understand is whether chest x-ray, which is the current first-line investigation for lung cancer, should be replaced by low-dose CT scan instead. Now, chest x-ray is currently the first-line test in general practice for all symptoms of possible lung cancer, except for haemoptysis, and that is in the NICE guidance. Unfortunately, we know that chest x-ray is far from perfect as a test. We know from research that our team has conducted that chest x-ray doesn't detect at least around 20% of cases of lung cancer in people who have symptoms who present to general practice. But most symptoms that could be lung cancer actually have a very low probability of turning out to be lung cancer, and that is really one of the strengths of chest x-ray, because it's a test that we can do in large volumes for an awful lot of people. This table presents in the second column the percentage of patients who have lung cancer who have particular symptoms, and in the third column, the rightmost column, the positive predictive value of one of those symptoms being lung cancer. Positive predictive value really just means the percentage risk that someone has lung cancer with that particular symptom. So you can see from this that cough is the most common symptom in over a third of patients, but because cough is so common in general, the positive predictive value, the risk that somebody who has a cough has lung cancer, is actually very low, well below 1%. Whereas haemoptysis, which is the symptom that we've always learned about in medical school as being the classic symptom of lung cancer, it is an important symptom because it has a very high positive predictive value of representing lung cancer of 2.4%. But actually, the percentage of patients who have that symptom is low. It's reported as 8% here, but that paper was from 2009. Actually, more recent evidence suggests that proportion is probably 5%, and maybe even going lower than 5%, probably because we're picking up lung cancer earlier and fewer patients are progressing on to get this more advanced symptom. Lung cancer screening is already with us in many parts of England, with people at high risk being invited for a low-dose CT scan. This has led many people to wonder whether this makes sense, that people who are invited for screening who don't necessarily have symptoms are being investigated with a CT compared to those who have symptoms being investigated with a chest x-ray only. However, giving everybody who presents with symptoms of possible lung cancer a CT instead of a chest x-ray would be a really formidable challenge. In England, GPs requested over 2 million chest x-rays in 2022 to 23, and that compares to less than 100,000 GP requested CT thorax and or abdomen in that same period. MEDLEY is a feasibility study funded by the National Institute of Health and Care Research, and it aims to find out if a larger trial comparing low-dose CT and chest x-ray would be feasible and acceptable, to work out if the costs of undertaking such a trial would be justified, and to assess the deliverability, acceptability, and impact of changing the pathway of first-line investigation for patients with suspected lung cancer from chest x-ray to low-dose CT across the NHS. Participants in MEDLEY will include patients who have attended general practice and have had a chest x-ray requested by the general practice team that fulfills NICE NG12 criteria for suspected lung cancer, and those participants would get a low-dose CT and a chest x-ray in that order. Recruitment will be by research nurse, mostly by phone, from the research sites, which will be the hospitals, rather than through the general practices themselves. Low-dose CTs will be arranged within 10 working days of the GP having made the chest x-ray request, plus a chest x-ray, which we hope will take place immediately afterwards in most cases, or no later than a further 7 days if for some reason it isn't possible to do the chest x-ray on the same day as a low-dose CT scan. The low-dose CT will be used for clinical management, and a report will be issued based on the low-dose CT and the interpretation of that from the radiologist and the site study lead, who will be a respiratory physician in most cases. The chest x-ray will be used for the study purposes only in terms of comparison of the chest x-ray to the low-dose CT scan. For patients to be eligible to participate in MEDLEY, they need to fulfill the NICE NG12 symptom criteria, excluding haemoptysis. So patients who are coughing blood are not eligible to participate, and the reason for that is the standard of care as suggested by NICE is that those patients should have a referral, an urgent suspected cancer referral in any case, and probably those patients will be getting a CT anyway. These are the NICE NG12 symptoms, and the guidelines say that people with these symptoms aged 40 and over should have a chest x-ray. So the guidelines divided into people who have a smoking history and those who don't have a smoking history, and the guidelines say that those who have not smoked require 2 of the symptoms in the top part of the slide to have a chest x-ray, or if they have smoked, then 1 symptom. Patients who have signs including persistent or recurrent chest infection, finger clubbing, lymphadenopathy, chest signs, and thrombocytosis can also have a chest x-ray according to the NICE NG12 symptom criteria, and that is not contingent on smoking history. For patients to be eligible to be considered for MEDLEY, the study team need to know that they have these NICE NG12 symptoms. So only patients who have those symptoms recorded in the clinical information of the radiology requesting system would be eligible to be contacted for participation in this study. They'll also, of course, need to be 40 or over, as stipulated in the NICE guidelines. Will need to know their smoking status, and in several of the areas in which MEDLEY is being undertaken, the radiology requesting system has been amended so the smoking status is included, and we've also amended the radiology systems in some areas so that there is a box which asks the requesters of the chest x-ray to state whether the x-ray is being requested because of the possibility of lung cancer. It might say something like, are you requesting a chest x-ray because of the possibility of cancer? This would need to be marked yes for patients to be considered eligible to participate in MEDLEY. As of August 2025, we're planning to recruit patients to MEDLEY who have had chest x-rays in practices which are served by hospitals in these 5 centres: Leeds, Hull, Stoke-on-Trent, Manchester and Bath. In each area where MEDLEY is taking place, recruitment will be happening for up to 1 year. About 5 participants will be invited at each site per week. This represents a very small proportion of all the GP chest x-ray requests at each site, but it's important for you to be aware that the study is happening if you're working in one of these areas. If one of your patients is recruited to MEDLEY after you've requested a chest x-ray, no action will be required from your practice or yourselves. The recruitment and all of the business around recruitment will be done by the MEDLEY study team in the hospital in each area. If a patient is recruited, the chest x-ray that you requested will be cancelled by the study team, and a report will be issued in place of that chest x-ray request, which will come to you in the usual way, and that report will just say that the chest x-ray has been cancelled because the patient has been recruited to MEDLEY, and instead you should expect to receive a letter with the CT result and recommendations from that instead of the chest X-ray result. And the letter that you receive with the results of the low-dose CT will look something like this. The first part of the letter really explains the study again and that your patient has been recruited to MEDLEY, so hasn't received the usual chest X-ray and you haven't received the usual chest X-ray report. And then the second part of the letter will give the details of the low-dose CT report and any recommended actions which have been set out by the study PI at each site. Actions that are required that arise from the low-dose CT scan that require follow-up in the hospital. So these could be things like incidental findings of lesions in the kidney or nodules in the lungs that require follow-up. Usually these will be arranged by the study team at your hospital site. If a patient does not attend the study low-dose CT or the chest X-ray, the study team will try to reach the participant to rearrange this, but if they cannot, they will write to the participant and ask them to recontact their GP to consider doing their chest X-ray request again if they still have symptoms. And the reason for this is that as part of the study, your original GP request for the X-ray would have had to been cancelled. So that patient, to get an investigation, would have to go back to you and get that GP chest X-ray request done again. We hope that this is a situation that arises very infrequently, if at all, and we do want to reach these participants to get them their study scans. We appreciate there could be some small extra workload if patients do not attend and then subsequently contact GP services to have their chest X-ray requested again. If this was to happen, this will be an important finding from this feasibility study and would definitely inform any further larger scale study on low-dose CT instead of chest X-ray. As part of the study, we will be talking to some patients who have participated in the study and also some patients who have chosen not to participate in the study to get their experiences of low-dose CT or their reasons for not having low-dose CT instead of a chest X-ray, and we'll also want to speak to general practice teams to have their thoughts and perspectives on MEDLEY, both in terms of the study and how it's worked, and also their thoughts and impressions on whether low-dose CT should be used instead of chest X-ray for some or all of these patients with possible lung cancer symptoms, and if that were to be implemented, how that should best be done in the future. So, just to summarise, lung cancer is our leading cause of cancer death in the UK and worldwide. Chest X-ray is our first-line investigation for lung cancer from general practice for almost all symptoms, but lung cancer is often missed on chest X-ray, but symptoms that could be caused by lung cancer are so common in general that the case for using low-dose CT for all of these patients is not at all straightforward, which is why we want to do this study. Adopting low-dose CT as a first-line test instead of chest X-ray would have many consequences for patients and GPs. We need to understand these before we make any change, rather than just implementing a new policy wholesale. MEDLEY will involve a very small proportion of patients who are referred for chest X-rays from general practice having a low-dose CT instead. GPs aren't required to recruit to the study, but we want to make sure that you are aware, if you're working in one of the areas affected, that some of your patients may be having a low-dose CT instead of the chest X-ray that you requested. And we really want to capture views and experience of GPs who are working in the areas in which MEDLEY is undertaken, and we will be doing this by qualitative interviews at a later point. If you want to find out more about MEDLEY, please go to our website ctru.leeds.ac.uk/MEDLEY and click on the Health Professionals tab, or email us on medley@leeds.ac.uk.